Good afternoon, everyone, and I would like to thank Dr. Malay and Dr. Chawla for giving me this opportunity. I will be talking about what is the role of laser in today's scenario. My slides are not moving. So, as being discussed, it is a leading cause of blindness and diabetes with prevalence which is more in type 2 diabetic, and it is 3% in 5 years, which goes to 28% when it becomes a 20 years of type 2 diabetes, while in type 1 diabetes it is around 27% down the line of 9 years. As being said before, according to ETDRS, we call it when there is a retinal thickening within the 1 disc diameter from the foveal center with 2 disc diameter wide, or there could be a various classification as being discussed before. It's a focal macular laser with an hard exudate with a leaking microaneurysm in the center, or it could be a diffuse edema which is due to the larger breakdown not only of a microaneurysm but also the capillaries, which shows an extensive leak on FFA, and the center involving and non-center involving, which is an OCT classification involving 1 millimeter of the central zone are outside. And then clinical significant macular edema, which we initially used to document and do according to before the development of an OCT. But then what is the effective strategy to treat a macular edema? We all know it is a multifactorial disease. There are many things which are involved in the pathogenesis. So we cannot take one factor into the consideration. We have to take all factors, and then we need to individualize the treatment. And it has been said and seen that 30 to 35% of the patients, they resolve spontaneously if you see them for 6 months. And treatment, which one is very important, but what we discussed is to a good control of diabetes. But then that good control of diabetes in the initial years are very important. So when you start the treatment and if you reduce the HbA1c, it will reduces the risk of retinopathy by 30 to 40%. So our patient will be for the prevention because of the metabolic memory. They will not develop or progress to a diabetic retinopathy. So the first line of treatment is not only to control the sugars but also to control the blood pressure, lipids and associated pathologies, which will control the disease and the edema by 35%. And then there are various studies which is being discussed, that there are so many studies which come across giving us the importance of each and every aspect of treatment of diabetic maculopathy. As said, central involving with anti-VEGF, steroids and anti-VEGF in combination, or vitrectomy when there is a taut hyaloid membrane, or lasers when there is a non-center involving macula. So what is the role of laser? So when we had that ETDRS study, which was a very rigorous multi-centered randomized trial, which shows us the benefit of DME, which reduces the risk of loss of vision in 50% of the patient, but it was minded 3 years as compared to a control. And it is being said that the mainstay of the treatment of diabetic macular edema is lasers before this trial came in 1985. And only there was a 3% gain. That means the vision gain is not our priority. Our priority is to stabilize the vision. So what are the parameters which are being used? The focal laser, it is in the ETDRS, it is a spot size of 50 to 100 microns with 0.05 to 0.1 second, and in the grid laser in a pattern of grid on a temporal side with 50 to 200 microns with a duration of 0.05 to 0.1 second. And the mechanism is basically to reduce the oxygen to the retinal areas and destruction. So the side effect is that they will extend and they will create a central loss of vision and central scotoma, and they alter the vision, and they may incite into a neovascularization and subretinal fibrosis. That is why the modified ETDRS techniques are a mild macular grid techniques came into the consideration. But then this being replaced by anti-VEGF when we had these anti-VEGF multiple trials. But then all those trials which are being shown here, the red trial, the restore, and the many other, they are all showing the importance of using an anti-VEGF in macular edema, but they have not told us the answers for macular laser for such patients. And most of the studies in this paragraph number 3 can say that it is being studied only for 1 year. So we have been seeing the efficiency for 1 year, not for the 2 and 3 years, which ETDRS study has done it. And then many of these RCTs, they are being done in a controlled environment for the center involving, but we know that our DME patients, they are not having a single phenotype, they have a different morphological variabilities. And then we know that most of the studies, there could be a leaking microaneurysm outside the fovea, and in restore trial themselves also, 33% of the patients, they show the leaking microaneurysm outside the central zone, which needs the laser. And even the sub-analysis shows that the retinal thickening of more than 300 micron, they responded very well to the macular lasers. So not only this, but then we have not studied the non-center involving macular edemas. So parafoveal macular edemas definitely needs a laser. Even in the DRCR net protocol V, they have said that you observe the patient, but in 36.7% of the patient, when they observed and if they subsequently develop the macular edema, vision loss, their vision progressed to the worse, and they had a poor visual outcome in spite of giving the anti-VEGF. This is probably because of the long-term photoreceptor damage. So that is why we have to do a laser treatment for non-center involving macular edema also to protect the vision loss for the future. So all these studies, they are well designed with a regular follow-up, which we don't see in our normal clinical scenarios. 25% of the patient may lose to treatment or may lose to a follow-up. So if there is a non-compliant patient, especially non-center involving macular edema, why not to give a laser, and it is a viable option to prevent the vision loss. And even the DRCRS net protocol T has been showed that intensive anti-VEGF therapies under the trial condition, the macular laser treatment still needed in 37 to 56% of the center involving macular edema also during the first year of the treatment. And then not only this, there are many issues which are there with the anti-VEGF. There are few patients which may not be responsive to multiple injections. There could be a macular atrophy, and there could be a risk of complication, though very small, but then endophthalmitis, retinal detachment, and even the strokes. So what is the role today? So definitely it is having a role as an adjuvant therapy or synergetic activity with the anti-VEGF. There will be a greater reduction and the long-lasting effect. So if you want to have the improvised effect, it will be more with the lasers, and they will require the number of injections lesser in comparison to when you give anti-VEGF alone. So combination therapy definitely works better, and the amount of the laser energy which is required when you do a combination therapy will be lesser, so the complications related to the laser will be lesser. So in present scenario, the lasers can be used for the focal diabetic macular edema. The grid will be used only for resistant and contraindicated cases where we cannot use anti-VEGF. But then we have to simplify the treatment because multiple follow-ups may not be possible with our patients, and also the concern of the cost. So we have to do a laser, and then we should think of a newer laser technologies like sub-threshold macular diode laser, selective laser therapies, so that we should avoid the destruction more to the surrounding retina. And the selective laser diode micropulse therapy is very promising. It reduces the amount of the damage to the retinal pigment epithelium, and it is very fovea friendly. So you can do even the foveal lasers. It has a repetitive effectivity, and the TXL guided micropulse therapy also help in settling the size and the duty cycles. So because of that, the damage is not to the extent of higher density applications, and we can also have an image-guided photocoagulation. So to conclude, the monotherapy macular laser treatment, though it has lost its role as a gold standard treatment, but has an important role in combination with anti-VEGF and the grid laser in resistant and contraindicated cases where we cannot use anti-VEGF. And macular laser is going to stay, and it will be in the different form, maybe subthreshold or many other good lasers. Thank you so much for patience listening.